Hi, I'm Dr. David Jobes. I'm a professor of psychology at the Catholic University of America in Washington, D.C. I'm going to be describing to you the treatments for suicidal risk, what's established by the research literature, what's emerging, and different sort of aspects along the way. When we think of treatments for suicidal risk, the way I think about it as a treatment researcher are interventions that are typically suicide focused, that have been proven to be effective in randomized controlled trials. RCTs are the way that we understand a causal impact of an intervention, like COVID-19 vaccine. We learn about the causal impact of an intervention by having an experimental group, which is the target group, and the control group, and then comparing the two to see how an intervention works. In that regard, the highest level of rigor are randomized controlled trials where the results are replicated, and ideally replicated by independent researchers. So it's not just the developer of the intervention, but also people that are working independently. So it's an independent validation. And we like to see multiple replications. So when we look at the research at the highest level of clinical trial investigations, the big sort of winning interventions for suicide risk are dialectical behavior therapy, or DBT, two forms of suicide-focused cognitive therapy for suicide prevention, CTSP, brief cognitive behavioral therapy for suicide prevention, BCBT, intervention called CAMS, the Collaborative Assessment and Management of Suicidality, which is developed in my lab, and then an intervention called Caring Contacts. So I'm going to walk you briefly through each of these interventions and then talk about other emerging and developing areas of treatment research. Dialectical behavior therapy by far has the most evidence. Over 24 randomized controlled trials demonstrating its effectiveness across different conditions. With regard to suicide, there's at least 20 trials where we clearly have evidence, replicated evidence, that DBT effectively reduces attempt behavior and self-harm in comparison to controlled treatment. Now, another important aspect of randomized controlled trials are meta-analyses, which are studies of studies. And the meta-analyses in support of DBT are quite clear and robust. DBT doesn't necessarily reduce suicidal ideation. It's much more behaviorally focused treatment, but it's a very good treatment. There are 4 components: the development of skills, individual in a group context, an individual arrangement to sort of work on those skills, phone coaching, and then consultation for the treatment team to work in support of the client and patient. So DBT's got by far the best data, the most replicated data, the most independent data, and meta-analytics support. Cognitive therapy for suicide prevention, developed by Greg Brown and Aaron Beck, is a very effective intervention that's been replicated in a similar kind of intervention by David Rudd and Craig Bryant, called CTSP and BCBT, respectively. By the way, the development of DBT was developed by Marsha Linehan at the University of Washington. These treatment researchers are all after a very particular focus, which is the impact of these interventions on reducing attempt behaviors. They're behaviorally oriented researchers. CTSP and BCBT have been shown to reduce attempt behaviors by 50% in the former and 60% in the latter in 2 different trials, replicating that big finding. But what's interesting about these interventions, like DBT, they don't necessarily reduce suicidal ideation. So it's kind of a bifurcation of the effect of treatments in our field. But reducing suicide attempt behavior is a big deal, and these interventions, these cognitive interventions, have been proven to be quite effective in that regard. CAMS, the Collaborative Assessment or Management of Suicidality, is a therapeutic framework that focuses on suicide. There's an emphasis on empathy, collaboration, honesty, and being focused on suicide. A novel thing about CAMS is that we emphasize a focus on what we call drivers, which are the problems that the patient says makes them consider suicide. What guides the CAMS intervention is something called the Suicide Status Form, which is a multi-purpose assessment, treatment planning, tracking to clinical outcome tool. A lot of the documentation is completed sitting side by side with the patient. And there's a web-based version of this as well, a fillable PDF that can be done in telehealth. There are 7 randomized controlled trials supporting CAMS, 10 correlational trials supporting CAMS have been published. and 2 meta-analyses. What CAMS clearly does, differently than the previous, is reliably reduce suicide ideation, maybe attempt behavior in one trial, with some promising data in another trial, overall symptom distress, and the single biggest effect for CAMS is increasing hope and decreasing hopelessness. So CAMS is extensively published literature, and 5 ongoing trials are underway around the world. Caring Contact is an intervention developed by Jerry Motto some 30 years ago, looking at how we can send simple communications with no demand on the patient or the client to respond back, saying, hey, we're thinking about you. We haven't forgotten you after they've been discharged from the hospital, from the emergency department, or other mental health facilities. Caring contacts have been replicated in different modalities, using text, using postcards, and the data shows that they can actually reduce completed suicides, attempt behaviors, and other suicide-related markers. It's a very simple intervention. You're just sending out a communication that we remember you, we haven't forgotten you, here are resources or ways to get more help if you need it. And these follow-ups are sent in a random way or sometimes very systematically, and they've proven to be effective. So those are the big ones. And you might argue that caring context doesn't really sound like a clinical treatment. That's probably true. It's an intervention. I would also say that safety plan type interventions or crisis response planning is another stabilization intervention, but in my mind, not really a treatment per se, or at least a clinical treatment. But these are nuances that are important. What I'm really focused on here are the treatments that have been shown to reduce attempt behaviors, suicidal ideation, and other related markers. Another intervention that's focused on reducing suicide ideation is attachment-based family therapy developed by Guy Diamond. And Guy's intervention has been proven to be effective in 2 clinical trials with replications underway. So like CAMS, it reduces ideation, may not reduce attempt behaviors, but it's a family-focused intervention with adolescents. And we have a dearth of interventions that are focused on young people. So Guy's contribution is significant. There are other interventions. The Attempted Suicide Short Intervention Program, or ASIP, mentalization-based therapy, interpersonal therapy. There are other interventions that have data showing an effectiveness for suicide behaviors that, in my understanding of the literature, needs further replication. Further randomized controlled trials and independent randomized controlled trials to really verify the effectiveness of these interventions. Technology is very hot and in use right now. Ecological momentary assessment, or EMA, has been used for basic research around understanding ideation and the incidences and how suicidal states wax and wane. But there's increasing discussion about bringing EMA into a treatment modality. There are others exploring the use of technology, monitoring, for example, texts or social media, and use of technologies to respond back to somebody who might look like they're getting in trouble. There are also interest in emerging technologies that have the virtue of kind of monitoring you and sort of notifying you if there's a concern. So for example, the one way to think about effective treatments is that they all, to varying degrees, create working models whereby when we get upset and our limbic system gets activated and the amygdala gets us into a fight or flight response, the prefrontal cortex shuts down. So a lot of what the proven interventions that I've described to you do is try to get the patient to re-engage the prefrontal cortex to downregulate a highly dysregulated suicidal state. So we think mechanisms are quite similar. What mediates these and the effects of these interventions we think is similar. We're starting to write papers that cut across different interventions that we think is sort of the secret sauce of what makes these interventions effective. What I would say is that they train the person who's suicidal to recognize who, what, when, where, how they get in trouble, and then things that they can do that typically re-engage the prefrontal cortex. So safety planning, or reaching out for help, or chain analysis are all working models that patients can learn about to engage when they get highly dysregulated in acute suicidal states. Emerging areas, there is a lot of excitement about the use of ketamine, IV ketamine. We have a clinical trial right now at the Cleveland Clinic and Mass General Hospital, and a larger trial looking at ketamine and ECT, electroconvulsive therapy. in combination with our intervention CAMS to see how CAMS works with these somatic interventions. There's always been and always will be a lot of interest in medications that can be effective for suicide risk. Clozapine is an atypical antipsychotic that has been proven, by my knowledge, by one RCT that the FDA approves. There's very mixed data on SSRIs and other psychotropics. What, in my mind, is clearly best are interventions that focus on suicide ideation and behavior. There is emerging evidence with PTSD, sleep, and perhaps eating disorders that treating those disorders can have an impact on suicidal ideation. But we'd like to see randomized controlled trials and replications and independent replications of those findings. Another area of a lot of excitement are brief interventions. This is the idea that you would have a one-touch, maybe a two-touch, three-touch intervention focused on suicide that might actually have an impact. Very minimal level of time and effort for a maximal outcome. So the Teachable Moment brief intervention developed by Stephen O'Connor is an example of this. It's a one-touch intervention done in medical surgical units. Peter Britton at the University of Rochester has developed a motivational interviewing intervention that is used in 2 to 3 sessions for somebody on an inpatient unit. The OSIP intervention that I mentioned earlier is a 3-touch intervention that has very clear, exciting evidence for reducing attempt behaviors up to 80% at 2 years follow-up compared to usual treatment. And that is currently being replicated and studied around the world. The other intervention is CAMS is a brief intervention, a 1-session use of CAMS, where we saw an effect in an inpatient unit in Louisiana. And we are now leaning into that research using CAMS brief intervention or CAMS BI, trying to replicate those data as well. There's interest in group interventions. We've used CAMS groups in the VA. There's no RCT, or randomized controlled trial, to prove its effectiveness. We have preliminary data that group modalities can be effective. Historically, there was some concern about groups being contagion or creating contagion among adolescents who might compete. But we published a number of papers showing that when veterans focus on suicide in a group context, it doesn't necessarily lead to a copycat or contagion effect. And the power of the group to support veterans can be quite compelling. But the jury's still out on group interventions. Obviously, we'd like them because they're more cost effective and you have the power of the group to support the intervention. A final comment I would make is that we have now these established interventions that are mostly focused on adult populations. So DBT, developed by Marshall Linehan, CTSB by Greg Brown and Aaron Beck, BCBT by David Rudd and Craig Bryant, CAMS, developed by my lab at Catholic University, Caring Contacts, which has been studied by a number of different groups, and these promising interventions like mentalization-based therapy and OSIP that really need further replication, further independence of findings. This is a robust body of evidence. What's interesting is that a lot of clinicians don't know about these interventions and rely, in my view, too much on inpatient care that's not suicide-focused enough, and medications that have minimal, mixed, or no impact on suicidal ideation or behavior, whereas they might help with other symptoms. With regard to these adult interventions, I think the evidence is quite robust that these are effective interventions that clinicians should and can increasingly use. There are emerging models of combining different interventions. For example, the Hope Institute at Perrysburg, Ohio is an example of combining CAMS and DBT skills group. And we have a number of studies looking at CAMS and DBT in combinations, treating different populations with different needs, with interventions that are well suited to each of them. Machine learning could be a part of this that could route patients to different treatments for whom they're best suited. Ron Kessler's notion of machine learning precision treatment rules is a very exciting concept that could save money and optimize our care. So we're good in the adult realm. We're much shakier in the adolescent and child realm. There's one book that was published in 1986 by Cynthia Pfeffer at Cornell on the suicidal child. We are now engaging on a pilot study with children who are suicidal, 4 to 11, and it's very exciting, but also a little bit scary when children that young are talking about suicide. There's a big parental and family component to that work. In the adolescent realm, we had DBTA with some preliminary evidence of effectiveness that was conducted in a randomized controlled trial. We need more replication. There's safety developed by Joe Narsano that has some promising data, but we need a lot more focus on teens and adolescents and to replicate that data and really show what the mechanisms are, what the mediators are, and how do we treat the child, but also work thoughtfully with the parents. For our part, we're doing research with CAMS for teens, where we had the parents engaged in a stabilization support plan, and also as a part of the treatment coming in at the end of sessions. But the treatment is for the child. We want the child to feel like this is my therapist, and my parents are in a support role, ensuring that lethal means safety are made secure in the home, and that they are supporting this treatment in optimal ways. So that's a very quick run through the research literature. We are in a very exciting time. I would say in the last 5 years, I've been at this for 40 years, we've seen more and more interest and focus on this topic. And the randomized controlled trials are really leading the way on interventions that are effective for treating suicidal risk, ideation, attempt behavior, and self-harm. And we need more of it to make the difference. And then clinicians actually need to use it. So thank you so much for listening, and good luck in the work that we do.